We're honored to have Mr. Frank Vitale to join us, um, who is the National Director of the Pharmacy Partnership and Tobacco Cessation. He's been in the smoking cessation field since 1987, so longer than a number of you who are in this world. So we can believe he knows what he's talking about, and we're just excited to have you here. Mr. Vitale, you can take it away.
As Norma said, my name is Frank Vitale. I am in sunny Pittsburgh right now, where it's a beautiful 60 degrees and the sun is shining. I'm assuming most of you are in California. Hopefully the sun is shining there too. So I've been asked to present on the medications that are approved for cessation. Usually this topic takes about 2 hours to cover. So I only have about 50 minutes. I'm not going to be able to go into a lot of detail about dosing and instructions and all that stuff. So what I've given Norma and the group is a handout that has all of the usage instructions, dosing, indications, contraindications, all that kind of stuff on it. Most of it is pretty clear cut and straightforward that you can see for yourself. Rather, what I'm going to do is try to go through some particulars about each one of these medications that I've encountered from, as Norma said, I've been doing this for 38 years now. So over all these years, some of the ins and outs that I've discovered and peculiarities and of using these products. So let's just jump into this. These are the objectives. You can look at that yourself. All right, so I've always used this paradigm as in doing smoking cessation counseling, and that is there are two parts to smoking, so there are two parts to quitting. Smoking is both a physical addiction to nicotine, and it truly is an addiction for 99% of the people who smoke, and it's also a behavior. It's a habit. And so in order to quit successfully, we know from the clinical practice guideline, which is a meta-analysis of over 8,000 research studies, that you need to deal with both of these aspects simultaneously. So what we're talking about here is getting into some kind of behavior change program, whether that is a individual counseling group, calling the quit line, using one of the programs that come with the medications, whatever it is, but dealing with the behavioral aspect of this while you're using a medication. So in this case, as opposed to many other medications, these meds do not cure you of smoking. What they do is something very important, but they don't actually stop you. You have to do that yourself by making the changes in behavior. And I'll go over exactly what they do in a second. So in this talk today, we only have time to go over the medication side, but I can't emphasize it enough. You need to join that with a behavior change program of some sort or another. Now, these clinical practice guideline, which is down in the corner there, and I would advise you all to get a copy of this if you can. It's the Bible, so to speak, of cessation. It indicates that everybody except these couple populations can use these medications. And these populations, and again, I don't have time to go into it, are not included in the guidelines simply because there have not been enough studies to include them. It's not that you can't use them with these populations. It's just the data is inconclusive. So I know many of you work with behavior health individuals, people with psychiatric and substance abuse issues. Note that this does not exclude that population from using these products. They can use all the products that I'm going to mention, especially the nicotine replacement products. So 5 of the medications are simply giving the patient nicotine in a different form. So remember this, they already have nicotine in their body from smoking. We're just giving it to them in a different way that is easier and more comfortable to stop. We know that using one of these medications alone doubles quit rates. And if you use them in combination, which we will be talking about toward the end of the talk, they can quadruple a person's chances of quitting successfully. So these are the 7 FDA approved products. This is all that the FDA has approved over the years. The first 5 are nicotine replacement: the patch, the gum, the lozenge, an oral inhaler, and a nasal inhaler. The first 3 are over the counter. The next 4 are prescription only. The other 2, besides the nicotine replacement products, are bupropion, which you all probably know as Wellbutrin, and varenicline, which is marketed under the name of Chantix, which is a medication in its own category. So what do these meds do? Why should you use them? Well, number one, they prevent withdrawal. And again, without getting into a lot of detail, many people who smoke go through significant withdrawal when they quit, so much so that it distracts them from really being able to focus on the behavior changes they need to do in order to stay quit. So this gives them just enough nicotine to prevent withdrawal and to help them feel comfortable. It also, and as important, eliminates the reinforcing effect of taking in nicotine through the lungs. So when you smoke, the nicotine hits your brain in 11 seconds. It's like this huge wham. And because there's so much of it and because it's so fast, it's very, very reinforcing. However, nicotine chemically has a very short half-life. So within 45 minutes, half hour, for most people, they're in withdrawal. So in order to get rid of it, they smoke. So all day long, the person's going up and down, up and down, up and down. And they're doing this behavior to prevent the withdrawal, but also to get the hit. They like that hit, that peak when it hits the brain, because it releases neurotransmitters, primarily dopamine, but also serotonin, epinephrine, norepinephrine, all those chemicals that make you feel good. So all the nicotine replacement therapies give you a lower amount at a slower rate so that you do not become physically addicted to these products. So remember those 2 words. It's good to use these products because they're lower and slower. So it eliminates the reinforcing effect and also keeps you out of withdrawal. So then you can comfortably look at breaking all of the habits around smoking that you need to work on. So that's a very, 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 very brief explanation of why these products are appropriate and good to use with your individuals who smoke. Now, the rest of the talk, I'm going to just go over each one of these products very quickly. Again, I'm not going to go over all kinds of dosing. You can look at that on the handout that I've given you. We'll start with the patch because that's been around pretty much the longest. It's the easiest to use. It looks like a big Band-Aid. It's in 3 steps, and you pretty much just take it off, put it on your skin. It's a transdermal delivery system, and forget about it. So this product is very good for people who tell you they don't want to have to think about quitting. They just want something easy to use that's discreet and is not, not a lot involved. You pretty much just put it on a dry, clean, hairless place. And that's really important because on a lot of men, they have a lot of hair all over their bodies. So you have to kind of, in some guys, really find a place to put this, because if you put it where there's a lot of hair, it's not going to completely adhere to the body. So you're not going to get the full dose. But when you go to take it off, it's really going to hurt because you're going to pull out all that hair. So, you can put it up here on your neck, up on the upper chest, pretty much anywhere on the upper body where there's no hair. And you need to rotate the site every day, because if you keep putting it in the same place, you're going to get a lot of skin irritation. Many people, the adhesive can irritate the skin, so it's important to do that. The side effects are minimal here. Mostly it's skin irritation from putting it in the same place. So again, you can mitigate that by rotating the sites and putting cortisone cream or Corday cream or something on if you get a little bit of an itch. The other interesting one is vivid dreams. Now, if you wear this, and you're supposed to wear it for 24 hours, you get nicotine all night long, obviously. And for many people, that stimulates the dream center in the brain, and they have very colorful, active, interesting dreams. Now, a lot of people like those dreams, so this isn't necessarily a problem. What you want to do is ask the person, are the dreams bothering you? Are they keeping you awake? If they say no, then don't do anything. If they say yes, then instruct them to take the patch off when they go to bed and put a new one on in the morning. So the research clearly shows that wearing this while you're awake is just as effective as wearing it all night long, because think about it, most people don't smoke while they're sleeping. However, the reason you're going to wear it for 24 hours is most people have the very lowest amount of nicotine in their body when they wake up, so they have very strong withdrawal. And we'll talk about a way to deal with that in a moment, if you're only going to wear this for the while you're awake. All right, again, I'm just briefly going to go through each one of these. That's the quick down and dirty version of the patch. I recommend this for people, as I said, who don't want to think about quitting and just want something easy to use once a day. On the other hand, if you have somebody that tells you, I want to be actively involved in my therapy, I really want to do something that shows that I am quitting, and I need to be able to be engaged with my quit, the gum or the lozenge are the perfect products. These are both oral products. The gum looks like a big chiclet. It is a resin based, and it just basically has nicotine in it, other than and flavoring if you get those. They come in 2 and 4 milligram. The dosing is based on time to first cigarette in the morning. So again, you can look at that yourself. This is the schedule. Essentially, you want to use 1 piece every hour on the hour, because unlike the patch, which passively gives you a nice steady amount of nicotine all day long, you have to dose yourself, give yourself that nice steady amount of nicotine all day long with the gum and the lozenge. So you need to really do a piece every hour in order to do that. Now, I do want to spend a minute or two talking about this. The problem with this product, I like it a lot. I was involved in a lot of the initial research with this when it went over the counter, is the fact that it's called gum. Because it's called gum, people tend to chew this like chewing gum. And if you do that, all the nicotine is going to go into your stomach. If that happens, guess what? It's pretty much useless, because your stomach is acid, nicotine is base. If you think back to chemistry class, when acid and base get together, it's neutralized. So it has really no effect. What you have to do with this is what's indicated on this slide. You just bite down on it, you activate it by biting down on it 6, 7, 8, 10, 12 times, whatever you need to get that tingly, peppery taste. That's the nicotine. As soon as that happens, you park it between your cheek and your gum and let it be buccally absorbed. The only place the nicotine can effectively get into your system internally, other than your lungs, is through this buccal membrane in your mouth. So the whole key to this is to leave it alone in that spot, so that all the nicotine on that surface that's exposed can leach into the system. Once that tingling disappears, and for most people it's a minute or two, then all the nicotine's been absorbed. So you bite down on it again, 3, 4, 5 times until you expose a bunch of new surfaces, and then move it to a new spot. Because this spot has been saturated with nicotine, it's not going to really absorb too much more. So you have to move it to another spot. So the whole thing here is this chew, park method. Now, this is a pain in the butt for many, many people. They just won't do this. It's too difficult. It takes too much time. However, there are many people who like this because it kind of mimics the behavior of smoking, because as I said, they're doing it about once an hour, and you have to move it around and think about it. So this is really good for people, as I said, who want to actively participate in their quit. And I'm not being funny here, this is good for people who have boring jobs. So if you're sitting in front of a computer all day, or you're a night watchman, or a truck driver, this takes a lot of work. So it eats up time, keeps you from thinking about wanting a cigarette. So I recommend this for that population. This is also good, and I would just got in on the tail end of the prior speaker. He was talking about weight gain. behaviorally, because you are having this in your mouth every, technically every 30 minutes of every hour, and you're not supposed to eat or drink anything while this is in your mouth, this can slow down or mitigate weight gain because you're not snacking as much because of the behavioral aspect of this. So if you are recommending that anybody use this product, please take time to go over this with them. Make sure they're using it correctly. If you don't have the time to do that, please refer them to a pharmacist so that they can do this. This, out of all these products, really needs to have a lot of counseling. The good thing about this is that you can respond to individual urges that might pop up in between pieces. So it's perfectly fine to use extra pieces during the day. After doing this all these years and years and years, the problem with this, I've never seen anybody use too much of it. Everybody uses too little of it. They try to use as little as possible, and therein lies another problem. So really, really, really inform these people, really focus on the fact that you need to use this consistently through the day and generally about 1 piece an hour. There are no contraindications to this other than if you have TMJ, simply because this is it's very viscous and it's very hard. So it might irritate your jaw. Other than that, and a lot of adults now have braces. They're straightening their teeth at an older age. So I wouldn't use this if you had braces because it gets caught up in there and can just be a pain in the neck. So if somebody wants to use an oral product and they can't use this correctly, or they're not allowed to chew gum, then they can use a lozenge. And this looks like Tums. And then there's a little version that looks like Tic Tac. Again, same thing. It's just has nicotine in it with some flavors. But what's nice about this is that you simply pop it in. Again, same dosing schedule. Just pop it in between your cheek and your gum and just suck on it. So most people can use this correctly, whereas the gum, as I just indicated, there's a lot of issue with many people not chewing it properly. So if you have somebody that wants to use something oral, and again, for both of these products, these are good for people who tell you they miss the oral gratification of smoking. If you look at somebody who smokes about a pack a day, and the average amount of puffs on a cigarette maybe are 10, 15, 20 puffs a day, they're literally putting something in their mouth maybe 500-600 times a day. So many people miss that oral fix they get from smoking. So this and the gum are good products for those individuals. Again, you just pretty much let this dissolve. It takes about 20 minutes and bing, bang, boom, you're done. So I like this product a lot simply because it's a lot easier to use. Now, when the products originally came out, there were all kinds of restrictions on it. And then in January of 2014, the FDA allowed the manufacturers to put these extensions on without doing a bunch of extra research. So the 3 things you can do with NRT here, especially these over-the-counter products, is you can start them prior to quit day. So you kind of can rehearse. So if you have someone that's scared of the quitting or afraid these products aren't going to work, they can literally do a test day just to see how it works. Or with the gum or the lozenge, they can smoke a cigarette at noon, at 1 o'clock, use a piece of gum, at 2 o'clock, have a cigarette. So there are many ways to fool around with this. Trust me, it's very, very difficult for anybody who's a regular smoker to get too much nicotine. So there isn't any problem with mixing these prior to the quit day. If somebody has a slip, so in other words, if they're on these products and they have 1 or 2 cigarettes in a certain situation, advise them to continue to use the product. There is no reason to stop any of them because of that. And then you can use these products as long as you need to. I have many individuals that I've worked with who are just scared to death of stopping nicotine altogether. So, you can use these for 6 months, a year. Now, I don't recommend that, and I'm not saying that you should recommend that, but it's not going to hurt anybody. I'd much rather somebody use a few pieces of gum here and there. Like my understanding is one of our former presidents is still on Nicorette gum, even though he's been out of the White House for many, many years. Again, the smoking is what's going to hurt them. It's all those chemicals that are in tobacco that cause all the medical problems, not nicotine. Nicotine's the addictive drug, but it's not the substance that causes all the issues that happen because of smoking. So they can stay on it as long as they need. Again, not recommending that, but the reality is some people just need to be on it longer. These are the precautions. And again, as I indicated at the beginning here, you can use this with almost any population other than individuals here who are experiencing some kind of major cardiac issues. But again, just refer them to their cardiologist. And I'll show you in a second, the American College of Cardiology came out with a white paper years ago that pretty much said, unless the person is having a heart attack right in front of you, you can use these products. So, these are just precautions, not contraindications. Pregnancy is on there simply because, we're cautious about pregnant women using any kind of medication. So again, from your perspective, unless you're an OBGYN, refer them back to their OBGYN and they will help them work with these medications. I've used them with pregnant women and have had no problem, and I have no problem recommending them. But again, you have to be a little cautious here. And then these are some of the studies to support this. Again, you can look at this on your own, but pretty much the heart conditions and the issues around smoking and heart disease come from the fact that they are not getting sufficient oxygen because of the increased carbon monoxide that's produced from the burning of the tobacco, not from nicotine. So these are perfectly safe products to use in that population. So those are the three over-the-counter ones. We have two oral. We have an oral inhaler with nicotine in it and a nasal inhaler. Just going to briefly go over these because they're not used very much. This one, as you can see, kind of looks like a fake cigarette. It has a cartridge that has the nicotine in a sponge. You put it in there. You can see that line where the mouthpiece comes off. And you put it in there. It cracks the seal. And then you puff on this much like you would a pipe. Unfortunately, this is a good product. I'm not quite sure why it has never taken off, but it hasn't. So I do know why this one hasn't taken off. I do know what the problem is here with the nasal spray. The nasal spray looks like looks like Flonase. I'm trying to think of, I use it every morning and I can't think of the name of it. It's the same as any kind of allergy medication that is out there in the spray. It's an aqueous solution. Now, I don't know of any clinician that is using this because of this fact. As you know, with any kind of medication, you have to do double-blind, placebo-based studies to get a medication approved. In that case, and in all cases, you have to, the placebo has to have the same effect as the medication so that nobody knows who has what. Well, guess what the placebo is for that they used in this study? And think about it. What do you think spraying nicotine up your nose feels like? Well, they used pepper spray. Yep, I'm not exaggerating. So this hurts a lot. It's very problematic and causes people to cough and sneeze and get headaches. And so again, in all my years of working with this, I've never recommended this for anybody. And I really don't know why this is still on the market because it is not used by most of my clinician friends. All right, so those are the nicotine replacement products. That leaves us with two other medications that we have here, bupropion and varenicline. Bupropion is Wellbutrin. Okay? It's exactly the same thing that is used for depression. It was called Zyban. So many, many years ago, I guess probably like 20 years ago at this point, a doctor out at Loma Linda VA Hospital was using Wellbutrin with her veteran population, and most of whom smoked. And she noticed one day that, most of the people that were taking Wellbutrin for depression had stopped smoking kind of spontaneously. So what they discovered when they did research after this was that amongst all the antidepressants out there, Wellbutrin increases dopamine levels. So it has the same mechanism in the brain as nicotine does without becoming addicting, and therefore allowed people to quit. So they manufactured this, came out as Zyban, and it was wildly popular. Many, many, many people used it. And then, like so many other things, it just kind of disappeared. And the sales dropped so much that GlaxoSmithKline just stopped making Zyban. So it doesn't exist anymore. It is now just generic bupropion or generic Wellbutrin. This you start like varenicline before you quit. So that was one thing a lot of people liked. You start this a week or so beforehand to build up a therapeutic blood level. The other thing that people liked about this is it's a pill. So you only need to take it a couple times a day. It's very easy to use. You don't have to think about it. So that's why it was very popular. And from a clinician point of view, you could kind of kill two birds with one stone by having treating the depression and helping them quit smoking at the same time. Now, there are a lot of side effects from this, especially the insomnia and the agitation. And so that's part of the reason why this kind of went out of favor. But primarily, it's the contraindications. This lowers seizure threshold. So anybody with any kind of seizure disorder, with any of these other issues here, could not take this. So clinicians started to shy away from it. But this is the real reason why it kind of fell out of favor, is varenicline showed up. So varenicline is a nicotine receptor agonist. It is in a class all by itself. And it was the last product that was approved for cessation, up till now. So you can see it's been a long time since anything new has happened. So what this does is it fools the brain into thinking that nicotine is there, so there is no withdrawal. But interestingly enough, it creates a barrier in the brain that prevents the nicotine molecule from getting to the receptor sites. So this is great for people who have tried before and have relapsed a lot, because if you're taking this medication, for the most part, when you smoke a cigarette, there's no effect, there's no hit. There's no pleasure from smoking. So there's really, what happens is if somebody's on this and they smoke, they kind of, okay, what's the point? I'm not getting anything out of it. So this was really good for the that population, and just in general for anybody wanting to quit. So we saw a huge uptake in this. Again, this is the dosing, et cetera. Here's some added information. The big issue with this was insomnia and nausea. And the nausea is caused because people were not using the product correctly. So you really want to make sure that they eat, take this after a meal and with a full glass of water. Now, in probably 8 or 9 years ago, all of a sudden we started getting a lot of reports of people who were on varenicline who were saying they were having delusional ideations and odd thoughts and just all kinds of neuropsychiatric problems. So the FDA decided to put a black box warning on the product, stating that if you were treating someone with any kind of psychiatric problems, to use this with extreme care. And because bupropion was kind of they considered it kind of in the same category, they put the black box warning on that. However, in a very good move, they said, well, we're not really sure what is causing these neuropsychiatric issues and why so many people are reporting them, et cetera, so let's do a study. So they funded this very, very large study. And anybody who does research can see that this was a unusually large cohort. So what they did was they got over 8,000 participants, half of whom had known psychiatric disorders. And what they were looking at is, did this medication actually increase the report of severe or moderate to severe psychiatric issues? So they had 140 centers, so this was all over the world, and they had 4 arms: people on varenicline, people on bupropion, people having the nicotine patch, and people in placebo. They did counseling with this. Again, extensive study, very, very well done. And this was the result. They discovered that the incidence of moderate to severe neuropsychiatric adverse events was essentially exactly the same for all 4 arms. There was no difference in the statistically difference in the reported events. So it wasn't varenicline, it wasn't bupropion. So what was the cause of all these problems? Well, many of my colleagues and I had thought this from the beginning. What these people were reporting was withdrawal from nicotine, not anything to do with any kind of medication they were taking. So the upshot here is that these medications can be used in psychiatric populations. There is absolutely no problem with that. And the other interesting finding from this study is that we now, for the first time, had head-to-head study amongst the medications, and we discovered that clearly varenicline does produce the highest quit rates. So, we can now very clearly say that varenicline is probably better than any of these other. So the takeaway for you, especially if you're in the psychiatric substance abuse arena, is that this study very clearly shows that you can use this medication. However, I do recommend, as I do with everybody, that you follow people closely for the first couple of weeks after they quit, just to make sure there are no other issues. Now, the standard for treatment amongst all my colleagues right now is combination therapy. So what we're talking about here is using 2 or more of these products at the same time. Essentially, that is using the patch, which is I say kind of gets rid of the underlying withdrawal, all the general withdrawal, and then adding on the gum, the lozenge, the inhaler, the nasal spray, PRN. So here you can use these products PRN, whereas if you use them as monotherapy, you want to use them steadily through the day. You want to use these short-acting formulations to deal with situational urges where a person needs just that little bit extra boost. So what I find here is that most people who do this will do it, the second product, for the first couple of weeks just to get them over the hump, and then they stay on the patch for the recommended period of time. Pretty much this is what everybody's using right now. We're just starting people up with the patch. I use the patch and the lozenge most of the time. And we find that that's producing much better results than just using one of them alone. Bupropion and NRT, that was studied in one of the initial arms when bupropion was looked at as a cessation medication. So there is some improvement there. And right now, there is no real data on using varenicline and bupropion together. And varenicline with NRT, because it blocks the nicotine from getting to the brain, it only might help a little bit. So again, there's not much evidence there. I would just go with the patch plus one of the other products. Again, completely safe. There is very little chance that your people who smoke are going to get too much nicotine from. These are the combinations that the clinical practice guidelines felt there was enough clinical data to recommend. Now, there's all kinds of other stuff out there. Our lovely internet has everything in the world. with nicotine in it. You know, these have kind of all fallen by the wayside. None of them work. There is no data for any of these products, so don't even go there. These have all fallen to the wayside because of this. So I don't think I can be any more clear. Vaping, e-cigarettes, Juul, any of these products, right now, there is not enough information, there's not enough data to say that they are effective, there's any efficacy in helping people quit smoking. What we have found very clearly in most cases is if people do this to quit smoking, they end up doing both smoking and vaping. They vape when they can't smoke, they smoke when they don't want to vape. So right now, if there were no other medications out there, if there were no other products out there, I would be telling you something completely different. But we have 7 medicines that we know are safe and effective, and I would not go into this arena with these products. Yes, they may be safer than smoking because they don't have tobacco in them for the most part, and they don't have all those other chemicals, but it's a say that they're safe. So again, we have 7 other products, go with them. All right, now I finally want to end up with another issue here that you may not be aware of, but it's very, very important. And I've given you a handout for this also. So what we know very clearly is that there are drug interactions between something in tobacco smoke and many, many medications. And what that is, it's the hydrocarbons that are in the smoke. They rev up the CYP1A2 pathway in the liver where many, many, many medications are metabolized. And what they do is when you smoke, you actually need more medication because it's burned up faster. So that when you quit, you need less medication. Now, why is this important? Well, in the past, before we knew this, we would have somebody on one of these medications. And as you can see, there's many psychiatric medications on this list. Somebody would quit smoking, all of a sudden would have all of these strange things happening, which they would attribute to withdrawal and therefore go back to smoking. But it wasn't withdrawal at all. It was too much medication. So it's very, very important that any patient on any kind of medication that you look at the dosing when they're quitting and adjust it, usually downward when they quit, because they don't need as much medication as when they were smoking. As I said, I've given you, we update this list from the RX for Change program regularly. So I've given you a handout that has the latest up-to-date info on which medications are affected by this. This is not an interaction with nicotine. It has nothing to do with nicotine. It's the hydrocarbons that are resulting from the combustion of the smoke. So understand that. It's interactions with smoking, not with nicotine. So my recommendation here for you is to work with, if you're not a physician, to work with the patient's physician and adjust dosing on these medications as. You may have to do it a couple times until you get to the right dosing. And this is very individualized and we don't really have any kind of test to know how much the medications are being affected. It's pretty much individual to report that to us. All right, again, I know I went through this very, very, very fast, but hopefully give you a very high level view of these medications. Again, I've given you that chart that has all of the ins and outs with it. In summary, again, as I said at the beginning, the best way to quit smoking is to combine a cessation medication with a behavior change program. And by the way, I mentioned vaping, not to use vaping as a way to quit smoking. Many of you are dealing with now people who want to quit vaping. There has been very little research using these medications for that, but intuitively, there's no reason why you can't, and many of my colleagues are using these meds. So that brings up the question, how do I dose? Well, the way to do that is most people who are using this are former smokers, so I would just look at how much they were smoking because what they've probably done with the vaping is come up or giving themselves an equivalent amount of nicotine and just dose based on that. If these are new people who have never smoked and they are, new vapors, pretty much go with the highest level of the dosing, because there's little way to know exactly how much nicotine they're getting. And I would rather go with a little higher dose than lower, and then adjust it as needed. But you can use all these products with anybody who actually wants to quit. And this is my contact information. I'm more than happy to talk to you about any kind of issues you have individually or with groups, or any kind of problems that you might want to discuss. Okay, Norma, if there are questions, I'd be happy to.
Yes.
I didn't see any of them, because if I look at the chat while I'm talking, I lose track of what I'm saying. So.
I know, I understand very well. Yes, let's see, we have a question. Which replacement therapy have you found that works better?
Well, as I said at the very end there, varenicline is statistically from the studies shown to be the best of all of them. If you want to use a nicotine replacement therapy, I use the patch plus the lozenge. That's pretty much my go-to right now. That seems to work best for most of my patients.
Okay, and what one of our co-PIs who does training says which one works best is the one that, excuse me, the one that the patient will take.
Absolutely right. No, that's that person's absolutely correct. It's whatever we use, and that's part of the reason. One of the things I go into when I have much more time to talk about this is very individualized. So you really want to ask a lot of questions, and one good thing to ask right at the beginning is, will you do something 10 or 11 or 12 times a day? If somebody says, what, I can't, I don't have time to do all that, then don't go with the gum or the lozenge or the sprays, because you have to do that a lot of times during the day. That can be a very simple way of cutting through all that and knowing very quickly that they either want to use the patch or take one of the medications.
Yeah, and I think Dr. Hurley will touch on some of that when he does his talk about changing the use of tobacco products a little bit later. And we appreciate you condensing this, because I know this could go on for many hours. There's a lot of information. One more question. Can a person that is taking medication for depression also take bupropion? To review that.
Yes. Yeah. I think you cannot take it with an MAOI, but
What's that? MAOI?
Mono. I don't remember the exact one, but anyways, it's that's one medication, but I don't think it's
monoamine oxidase inhibitors, but they're rarely used nowadays.
I knew it, but thank you. I think you can take it with many other antidepressants. But again, the issue there is to talk to the doctor, and maybe that's all you need is to take bupropion and not use another.
And one of the comments from Catherine, who was our first presenter, she says the side benefit of quitting is the need for less psychotropic meds. So this means less side effects, including those psych medications that have been attributed to weight gain, because we have a question about weight gain as well. And I think that might be the last one. Does varenicline cause weight gain?
No.
Varenicline / Chantix.
The weight gain, by and large, I mean, this is interesting. It does happen. I'm not denying it, but I know a lot of people who've lost weight when they quit smoking because they got more active. They felt better, so they got more active. From my perspective, I'm a behavioralist, so I kind of look at this from that perspective. If you think back, you're putting something in your mouth 500-600 times a day. So when you quit, you really miss that. And what's the natural substitute for that? Food. And because the fact that we know that smoking dulls the taste buds, so many people who smoke, their taste is kind of ruined. It's a mess. They really can't taste very well. But when they quit, those taste buds reawaken and everything tastes incredible. So not only are they eating more food, but think about it. What's the one ingredient in food that gives it the most taste? Fat.
Right,
So they're
right.
going after, they're not eating celery and carrots and radish. They're
Yeah,
eating
and I comment from
potato
Anya.
chips and cake and, candy. So not only are they eating more, but they're eating more fat. So they're doing two
Yeah.
things behaviorally. That's where the weight gain comes about. So
Right.
if you look at all the studies, if you do a meta-analysis of the studies, 1/3 of the people stay about the same weight, 1/3 of the people lose weight, 1/3 of the people gain weight. So it's not a guarantee. But if the
Okay.
person's concerned about it, then right from the beginning, do some stuff to mitigate the weight gain by, looking at fat content, looking at their eating, ramping up, as you said at the end of the last talk, getting some kind of exercise, walking in something that will mitigate that.
Okay. And I think this will be the last one. Based on the fact that there is high use of marijuana, usually coupled with smoking or vaping, are there any meds that help in stopping marijuana use that you know of? And I'll just say, even off label, what's being used now?
No. Sorry. Yeah, I know none of these, none of these 7 that I just talked about have any effect on marijuana. And that's not an area that I've really done much research. I'm not aware of anything that stops marijuana use.
Okay.
The supplement NAC is supposed to help marijuana cravings.
Okay.
Okay.
Thank you.
Great. We got so many specialists and skilled and experts on here. I'm grateful that we can bounce off of each other to get additional information. So I think that will wrap up yours.
Okay.
Frank, thank you again so very much.
You are most
I'm just
welcome.
ecstatic about our bevy of speakers today. Thank you again for joining us.
You're welcome. And don't hesitate to contact me if you need any more information.
Okay, appreciate that. Thank
Thanks.
you. Okay, bye-bye.
Best wishes with the rest of your conference.
Thank you much.
Bye-bye.
Bye.
Thanks so much.